I'm David Sandman. I'm president of the foundation. I could not be more excited about our guest today, Dr. Jeanne Lambrew, and about our topic, what's next for health reform? A big question, and one that obviously doesn't have a simple or any sort of clear answer to it. You know, I myself have been out doing a lot of speaking on that very same topic, and I start every single speech by saying, like I had to wake up extra early, read all the newspapers and all the blogs, and make sure the things I was about to say were still actually true. Because it does change really from day to day, or actually from tweet to tweet, it feels like. And even on the very same day, you can see 3 different statements from the President, Secretary Price, and Speaker Ryan. So it is hard to make sense of it on any given day, although we have some new leaks today telling us what perhaps the House might be up to. It's probably not so surprising, really, when you think about it, because the ACA, or Obamacare, whatever you want to call it, has been a roller coaster ride all along, from huge doubts about whether it was even going to happen, to a lot of implementation issues and stumbles along the way, and really multiple near-death experiences of the law, including the re-election campaign and multiple Supreme Court rulings. And our guest, Jeanne, she has been in the thick of it all and served in the Obama administration in numerous very, very high-level roles. For 2 years, she was the director of the Office of Health Reform within HHS, where she led the work leading up to the passage and the implementation of the ACA. And then she moved over to the White House, where she served as Deputy Assistant to the President for Health Policy, and really just had a vast portfolio there, including the ACA and Medicaid and Medicare and the Children's Health Insurance Program, and just about every other facet of health you can imagine. And people say, oh yeah, I had to go through Jeanne for that. So she is the woman, really. She's been right there on the inside, and she has such a unique perspective to share with us. She is a DC person, although she might deny it. She also served in the Clinton administration. But when she isn't hanging around the White House, she's a scholar and a researcher. She's been on the faculties of the LBJ School in Austin and the GW School of Public Health at Georgetown University. Just an incredibly impressive career she's had. But now she's here, spending about a month in residence in New York, splitting her time between the Century Foundation and the Wagner School. And once I got wind that she was here in New York, there was just no way we were going to miss that opportunity to have one of the nation's top experts come and talk with us. I've known Jeanne a long time. I'm just thrilled to have you here in New York and to welcome you to the foundation. She's going to start off with some remarks. She swears she didn't prepare, but I know she did, because I've known her. I'm going to ask her some questions, but really, given the caliber of who's in the audience, we want to save a lot of time for your questions. So get your minds going, get primed for that. So please, thanks for being here, and join me in welcoming Jeanne.
I will stand up and give very short, not very prepared remarks, as you can see from my scribble. But I do want to start by saying thank you. When I think through the experience of health reform, the role that foundations have played in laying the groundwork, providing the evidence, inspiring the work that is the foundational aspects of what works and what doesn't work in the healthcare system has been important. And I don't want to overlook the fact that the state and local foundations, I think, are particularly important because they inspire the kind of engagement and activism and insight that really does, I think, guide policy. So thank you for the work over the years that helped us get to this point. It is a special privilege to be in New York, because when we think through our experience in trying to figure out what works and what doesn't work, New York was a pioneer. Way before all of us came to Washington to work on health reform, we had the lessons learned from all the different state experiences, and New York State certainly was at our forefront, both in the areas of learning things that worked and learning things that didn't work, and we looked at that experience quite closely. And I am thrilled that some of our New York Exchange folks are here. One of my former colleagues, Sonia, and the team who has really stood up. The marketplace here in New York has done extraordinary work. We look to our state partners as role models, as providers of best examples, and as the people, again, who can mobilize communities to go that extra level that you can't do when you sit in Washington, D.C. and are trying to do a nationwide program. So the success that's happened here in New York is certainly something we're incredibly proud of. So thank you all for that work. So going back to this experience, and part of the reason why I have not totally prepared is it's hard to talk about a very intense, long experience, but it's only now a month over for me. But teaching has been good, and one of my students is here. What I learned the hard way is it's hard enough to teach what the Affordable Care Act is. It's even harder to explain to students why it was needed when you've been looking at a system for 3, 4, or 5 years that is working much better than it used to. And then fast forward, why are these people in Washington trying to change it? So I feel primed for a discussion about what is going on in terms of the health reform debate that we're having in Washington, D.C., but nationwide. But before we actually discuss the questions, discuss the issues, and I can offer what insight I have, there are 3 points I think I've learned from this experience that were a little bit there during the Clinton experience and my years in academics, but really were driven home in the past 8 years. And the first is that real change is hard. Hard meaning hard to design, hard to enact, hard to implement, hard to adjust, hard to have stakeholders embrace. And the amount of effort and time and energy that was dedicated to implementing health reform in the past 7 years is something I think people often overlook. To just give a few examples, when you look back on the debate that was happening 8 years ago, new president came in, we were talking about what was wrong in our healthcare system. We began with Congress already having had a year's worth of debates. We had dozens of congressional hearings. We had a White House forum where all the members of Congress came in March of 2009 to discuss and debate all these issues in a day-long forum. We had regional forums in California and a bunch of different states, and really had a very rich, robust, engaged debate. I say that because, in contrast, we have had one congressional hearing to date. We're hearing that this will all be done and done by the end of April, and I think the idea that you can change something as significant and broad-based and rooted as healthcare reform in this country in 6 weeks with one debate, one hearing, mild engagement feels hard to me. So lesson one, I think, is real change takes work. It's not clear that the work has been invested to make significant changes in the short run. The second is we had to very quickly get over ideology. That everybody has their favorite ideas, everybody has their ideal idea about how the healthcare system should work. And if we all were starting from scratch, I'm positive we would have had a different health reform plan in 2009 than we had in 2009, when we were primarily trying to take a system here and get to a new level. But in so doing, you have to be a pragmatist. You have to roll up your sleeves, look at all ideas that you didn't think might work. I mean, you know that President Obama was no big fan of things like the individual responsibility provision. He was skeptical that requiring people to have health insurance would be needed to make the rest of the system work. But we had people from Massachusetts come in, the researchers, we looked at the evidence, found no better way. So he put a practical lens on everything we did. Keep going. I can name a dozen ideas that we included in the law because evidence suggested that they would work. Flip it around. We also had ideas that we thought would work that didn't. There's many parts of the law that actually we tried and didn't implement because it just didn't work. One of the ones that makes us the saddest because of the need for it is the community, I never know the acronym right, CLASS, the Community Living Assistance Support System. Thank you. Which is a very important program to try to provide some sort of supports in the community for people with long-term services and support needs. Could not get it off the ground, could not implement it. A lesson learned both in things that we wanted to do that we couldn't, things that we didn't think were going to work that did work, but every step of the way in this intensity of our work to change the healthcare system, we put aside the ideology, we looked at the evidence, we tried to learn on the job, and we adapted, because you really can't make significant change if you're just approaching it from an ideological perspective. And the last thing I think we have learned, and this is the optimistic part of my remarks, is that once you do begin to make change, you develop these partnerships, you learn, you empower different actors and people in the system to make these differences. It's no longer a bill. It's no longer a law. It's no longer an Obamacare, piece of legislation, because it's so threaded throughout the healthcare system that it is hard now to say, take away Obamacare, take away Obama, and the thing stands up on its own. So many of our pieces of the law, which is called the Affordable Care Act, now are taken for granted in the healthcare system, and I am positive will continue and are not even being part of this debate. We're just talking a minute ago about Medicare. Will the Medicare components of the Affordable Care Act be repealed and replaced? The answer right now is no. Now, Medicare, for all of you who followed the debate in 2009, 2010, was a big part of the debate. It was not a minor part of health reform. It was a significant part of health reform. Yet the fact that we can have blithe conversations and talk radio, talk about tearing apart the Affordable Care Act, and yet the Medicare components of it are not even under discussion, is symbolic of the fact that the changes that have worked, that are working, that have helped people get health care that they need, that have made our system higher quality, that have made it more efficient, are now so part of the healthcare system, I don't think they're going away. So Obamacare, as the president said in a very funny speech in October, I never called it Obamacare. You can call it Obamacare. You can call it Ryan Care. You can call it Trump Care. I don't care. So he's called the I don't care bill. He doesn't care. This is not about him. It's not about, again, a law, something that happened in the past. It's how we have all been able to figure out ways to improve our healthcare system, and I think those are here to stay. So I'm happy to answer questions, although I will sit down, I think, for the rest of this, because it does get tiring teaching and talking instead of just working at a desk all day long.
So thanks, Jeanne. So why don't we start with like a very brisk stroll down memory lane, right? Barack Obama, as a candidate, did not run on a platform of sweeping federal health reform. His proposal was much more modest than Hillary Clinton's, and he wanted to do stuff basically for kids, right? So what happened?
So it is a fascinating period of time, because when you go back to 2007, 2008, there were state efforts to reform health systems. Massachusetts was being implemented. California was in the throes of a debate under Arnold Schwarzenegger back in that period of time. There was a business as well as a consumer group interested in health reform. I was working at the Center for American Progress, where we had a business and labor coalition that was quite aggressive. I mean, I was with the CEO of Walmart when he went into John Boehner's office to talk about why it is important for American business to have health reform. And then we had a bunch of candidates, kind of like last year's primary campaign and the Republican campaign, who were all vying for ideas. So in 2007, Center for American Progress and SEIU and a few groups did a candidates forum only on health reform. And the joke is that Obama went into it, kind of focused on healthcare, did his healthcare discussion, wasn't really happy with listening to other candidates and what he said, and then in the subsequent months worked harder on it. Fast forward to our first meeting in the transition in 2008 in Chicago, he, again, approached it in a very pragmatic way. What is the most effective, efficient, and best way to get from here to there? And if that means putting aside things that I said on the campaign trail, so be it. So we got that instruction very, very early, and it was what motivated us as we were trying to work with our friends in Congress, our friends with the Congressional Budget Office, outside analysts, to put together the building blocks of the bill that became the law.
And he sort of departed from the Clinton administration approach of having a very administration-led plan and task force and so on, and really left a lot of the crafting to the Congress, right? And was that deliberate?
Yeah, there's no doubt that there were veterans of the Clinton administration who were in senior positions at the time. Rahm Emanuel, who lived through health reform under Clinton, was chief of staff. Nancy Andaparo, who came in to help run the health reform effort, had worked at HHS and OMB during the Clinton administration. I had my experience, and I think we all recognize that a top-down approach would be a challenge. And I will again go back to the fact that there was a Congress ready to go. We had, Max Baucus and Ted Kennedy, subsequently taken over by Chris Dodd, ready to go in the Senate. We had 3 committees in the House, and then Speaker Pelosi pulled together all the committees and made them work on one bill because she wanted to advance it. So there was a lot of learning from the failed Clinton effort that went into the strategic approach to trying to get from point A to point B in Congress in the spring of 2009.
So you had a front row seat to history. Most of us are never going to work in the White House. Were there times when the White House lost its nerve? Obviously, there was the Scott Brown election, and said, maybe this is just impossible.
So I have become a interesting, observer of history, having lived some history, because there's a lot that's been written about the Affordable Care Act that doesn't look familiar to me. Just as a side note, I think history is your chair and your perspective, and sometimes you don't see the whole picture. I will just say that as a fact. So I can't speak to those moments like the Scott Brown election, and was there going to be a moment where we pulled away from health reform, where it almost didn't happen. I can say, though, that I always observed a commitment from the president to see this through. It is something I can say from all the low moments, because a significant amount of political and policy capital was spent in the Affordable Care Act. Trust me, I worked at Domestic Policy Council, where there were colleagues who wished they had some of the time, some of the attention, some of the bandwidth that we got in the healthcare arena to be working on different areas of social and public policy. But the president made a choice, and he made a choice to see it through, and see it through meaning not just get it passed, but get it implemented. Not just getting it implemented, getting it defended in courts. Not just getting it defended in courts, getting it up and going, with the classic example of healthcare.gov failures in the fall of 2013, where he spent significant amounts of time and energy and skill trying to get us back on track, and then using that lesson to make sure that government large writ doesn't have that kind of pitfall. So there were many moments, some of them externally driven, some of them internally driven, like the healthcare.gov failure. But at each moment, I will say it takes a leader with commitment to see it through, and we had that, President Obama.
Supreme Court arguments, right, didn't seem to go that well, right? Press reports said, for sure the individual mandate is toast, if not the entire law. Did you really think you were going to win?
So I am not a lawyer. I love lawyers now that I've spent much of my last 8 years around lawyers. I thank any lawyer in the room for all their hard work. So my job was not to predict whether or not the Supreme Court would act. I had zero basis for having any sort of predictive ability for the Supreme Court. The first time I stepped into the Supreme Court in the United States was to listen to the famous oral arguments that took place 3 days in March of 2009, where it still is a joke amongst my friends today. Was it a train wreck or a plane wreck? Because that was the news reporting, how bad was the oral arguments for the Affordable Care Act. But my job was to always think through worst case scenarios, right? Like, my job was to be ready under any circumstance, be it Supreme Court or other activities. And I will say, you talk about low moments, I was more fearful for the Affordable Care Act around that Supreme Court decision in 2012 than I was on November 9th, 2016, with the election of a president who said he was going to repeal the law. Much more scared then, because then with the Supreme Court acting, saying individual mandates unconstitutional, and there being no severability clause, meaning the entire law gets struck, we would have had to think through, go back again to what I described as a pretty broad range of services. While we didn't implement the class program, we did implement, for example, Money Follows the Person, a program that helps people stay in their homes with cash support. We would have had to, within a month, take that money away. We would have had to take the drug discount cards that we've been providing to seniors away from them within a month. We would have had to take away the medical loss ratio rebates that have been going out. We would have had to say to plans, never mind, don't cover all those preventive services benefits. So there are moments that have been more near-death experiences, and the Supreme Court one was one in 2012. Then I think what we're experiencing today, I am much more confident that the law will fare better under a Trump administration than under adverse Supreme Court decision.
Well, we're going to look ahead in just a moment. So
I can't believe I just said that.
It was recorded.
I know. Never mind.
Y'all tweeting right now. Okay. Maybe yet another low point was the rollout of healthcare.gov, right? And I think at least public perception never really fully recovered from that. Like, what went wrong?
There are many different takes on this. The president has articulated his own take on this. We certainly have seen different articles and descriptions. We just had our discussion about this in class today, so I will give my compare and contrast with Sherry Gleed, who is my friend and colleagues. She made a case that it wasn't just healthcare.gov. We had states like Oregon and Maryland and Massachusetts. Maryland and Massachusetts did not have functioning websites for the entire 2014 open enrollment period, full stop. We got ours going, they didn't. So her argument is the complexity of the eligibility for coverage in the Affordable Care Act made this a particularly difficult technology project, full stop. And if it wasn't very well executed, it was a higher probability of failure than probably anybody gave it credit for. I will say I can't get over my own feelings of culpability for not recognizing that high probability of problems, not identifying the appropriate management team to help the HHS people who were doing it, who said they had it under control, but we didn't. Obviously they didn't. And it was a self-inflicted wound. I think that's the way most of us would describe it. It was something that was not imposed upon us by anybody else. It was something that we brought upon ourselves. All that said, our leadership was of the view, you don't mope, you don't cry, you don't look back, you look forward. And within days and weeks, we got the system back on a track. As we were getting it back on track, we were parallel tracking our policy, our outreach, our engagement to supplement the gap in time that we had during that fall period where the website was functioning so poorly. That is, I think, why we exceeded expectations by the end of open enrollment, and then that wasn't good enough. We reorganized the way we do the marketplace at Health and Human Services. We reorganized the way we do management at Health and Human Services, so we brought in a lot more of a management focus, implementation focus, technological focus. We created for the entire government this United States Digital Services, recognizing that we have a lot of websites in the government, and there's a lot of risk in the government websites between IRS, the Veterans Administration, OPM, as we know, had a cybersecurity breach. So we created a toolkit and contracting models and a tech team that could be airdropped into different agencies to make sure this doesn't happen again. And one of the changes in the White House that got made was they took one of the most senior positions in the White House, which is the Office of the Chief of Staff, and created a Deputy Chief of Staff for implementation, whose job was to do nothing but follow and track and manage major government implementation projects. It was a person with as a war planner, who came from a national security background, who knew how to do that kind of sophisticated planning. And I think that has had spillover benefits that go beyond healthcare. So there's a long way of saying, there were a set of complex problems that went wrong. We did our best, it got fixed. We didn't have another website failure on our watch, which was something we're very proud of. And there's been spillover effects to different areas. Has that, though, really affected people's willingness to sign up for healthcare.gov? I don't know. And I say that because we're learning a lot about who signs up for healthcare coverage, and it's a pretty transient population. You have to every single year go out and find people who had been on their parents' plan and now are out, who are in between jobs, who are approaching retirement age. It's not a group of people who are homogenous and are going to come in and stay in. We're going to have to re-educate people about what is this place called the marketplace, I think, over time, because almost by definition it's a gap filler to our healthcare system. So I don't know that we have a lot of evidence that what happened now, 4 years ago, is affecting people's willingness to sign up today.
So let's go to a happy place, right? So walk us through the parts of the ACA that you feel have worked the best. What are you the most proud of if you had to pick, a handful of things?
I should have prepared more for this discussion. Well, look, I don't know how you can look at the uninsured rate in this country that's at a record low and say that's the best thing that ever captured. It really is, and especially we were looking at a map this morning in places like New Mexico and Arizona, and places you would never expect. I mean, we were thrilled with the fact that the major parts of the coverage expansion have worked. Would have worked better had the Supreme Court in the same day it saved the individual mandate, not struck down the Medicaid requirement for all states, because we do know we still have significant gaps in states like Texas and Florida. But it really is something that we feel incredibly proud of. But the president was very insistent that we focus on affordability, because his view is, you don't have sustainable coverage if you don't have affordable coverage, and we have to always work those in parallel track. And we are thrilled with the fact that while healthcare cost growth still grows, it is not the double-digit growth rates that we saw a decade ago. We have seen considerable improvements in the Medicare financial outlook. Employer-based coverage has had 3-4% growth in the past number of years, which again may be a little bit higher than wages, but well below what medical trend had been before the law passed. The Medicaid expansion has happened with Medicaid per capita spending dropping in a lot of areas. So the cost story is one that economists don't like to attribute to particular pieces of the Affordable Care Act. Causality and evaluation make it very difficult to say, is that due to the Affordable Care Act or other structural changes in the healthcare system or the recession, you name it. But there is an agreement that we have seen almost historically low cost growth since 2010, and some of that can be attributable to the law. So those are two examples. My quality friends would be angry if I didn't mention the fact that they spent a lot of time trying to figure out how we give healthcare providers in America usable data, good data, interoperable health records, feedback, so that they can begin to incorporate their own performance metrics into their daily lives. I think we've seen improvements in patient safety, avoidable readmissions, and a few of our other quality metrics. I think we have more work to do in that area, and I'm hoping with some of the implementation projects that will certainly continue in the coming years, we'll see greater gains in that area. But it was always, the access, cost, and quality triangle that we were measuring ourselves against, and I think we obviously have challenges, which I'm happy to talk about, but in the big picture, it's hard to say the law didn't achieve its goals.
And what didn't come to fruition the way you would have hoped? Or I'll ask you a different way. If you had a magic wand and you could change anything you wanted, one, you'd obviously restore uniform Medicaid expansion across the country. Beyond that, what changes would you like to see made?
There are probably two, and they do go back to a little bit of the genesis of this debate. Now, granted, I think this debate may be not about the actual law and its performance, but about, politics and people. But putting that aside, we did see high premiums for 2017 in the individual market in some places in the country this year. Some of it was predictable because of the end of some of our programs. Others were because some of our programs that are designed to stabilize the marketplace were hamstrung by a variety of different congressional actors and limitations associated with it. Had those market stabilization provisions been as rich as they should have been, I think it would have been better. Had we also, I think, been able to figure out safety nets and fallbacks for the individual market in a better way, I think it would have been better. We had a vigorous debate in 2009 about whether or not there should be a public plan as a choice in the marketplace, then whether or not it should be a fallback if there's no private choices in a particular area. And that devolved into co-ops and other different kind of stopgap measures to make sure that there was a choice of health insurance providers in all areas of the country. I think none of those fallback ideas have worked particularly well. And without a public plan fallback, I think we find ourselves with some states with very high costs that are unnecessarily high because of, both the lack of a better stabilization system for the individual marketplace, again, in part because of some trips with Congress, but also we just didn't have the kind of fallbacks in the original design of legislation that we would have liked.
It's not uncommon in public opinion, but I mean, there's been this schizophrenia in the country around the ACA on so many levels, right? Many states who stood to gain the most were among the most resistant to the ACA. But some of the public doesn't know that the ACA and the Obamacare are the same thing, but they do poll very, very differently, which is not so uncommon. Weirdly, public opinion about the ACA has been incredibly stable over the years.
Actually, I just need to say something mean for a second. So the Pew Charitable Trust put out a survey 2 days ago, yesterday, that showed that the Affordable Care Act is at its peak of popularity right now. I'm like, where were you people? Where were you? I was like, we needed you. Anyway.
So for the New York crowd, I should tell you, it was at a PCDC event, and Mayor Bloomberg was being honored, and he spoke with great pride about what he had done to control smoking in the city, and the healthcare crowd stood up and applauded, and they loved it. He was like, "Where were all of you when I was marching on Staten Island and getting booed?" So how do you explain that? Like, why is it at its zenith of popularity now?
There are behavioral economists who can articulate this a lot more scientifically than I can. But I think we are seeing a phenomenon, which is the difference between a plus and a negative, right? So we were at a place where we were trying to advance public policy, build on something, create something new that hopefully would be attractive to people, hopefully would provide them with the level of expected health care that they wanted. Expectations are very hard to meet. Despite, I can give you many statistics about how the law performed, that doesn't matter to a family that feels like it still can't afford the deductibles, still can't afford the premiums, they still can't see the doctor that they want. So I think it's always harder to create something new against a baseline of expectation that, I'm not judging that expectation, but it's oftentimes a harsher judge than flip it around. The new change is taking something away. So people may not like that same health plan that they have, but it's better than it was before the law passed. It's better than nothing, which is an option right now. It's better than some replacement plan that nobody has seen. So I think that the flip of the default from being, for the past 7 years till January, it's the law of the land, how do we improve it, make it better, versus we want to throw out the law of the land and start from scratch. It makes those elements of the system that are working functionally well more precious to people, and the nature of healthcare as such, and I just have been watching some of the town hall meetings this week, it's also very personal to people. It's very personal. This is like, there are people who talk about their coverage being the difference between them and bankruptcy, between them and not getting their needed health care, between them and life and death. And that's something that is real in a world where there is a risk of rolling back some of the coverage expansion, with the idea of replacing it with, again, something that nobody has seen at this moment in time. Although apparently it's been leaked, so we'll see.
Yeah. So let's look
Yes.
forward, right? And I'll ask you the impossible questions of what's going to happen. It's only been, I don't know, six weeks or a little bit more. I mean, the catchphrases have changed a lot, right? From repeal and replace to repeal and delay to maybe we'll repair the law. So, given everything you've been through, you've been through the ringer multiple times. You've said things are hard. What's your best prediction as to where this ultimately really winds up?
I don't know that I can predict. We haven't quite seen this constellation of players, and let's just walk through it for a second, right? There's a president who, if you look at his words in isolation, doesn't look tremendously different in terms of what the outcome he wants than the former president. He wants to make sure people with pre-existing conditions have protections. He wants to make sure there's not a day when somebody lacks coverage. So we have a set of goals being articulated by the president that sound similar. And President Obama said this in January, look, I'll applaud him if he can cover as many people with as high quality, as affordable coverage. I'm with him. We have a Secretary of Health and Human Services that has a plan that is quite at odds with that in terms of his own predilections, his own views, which he did walk back from in his confirmation hearings, as one does when you're being confirmed to work for somebody, but unclear whether the administration as a whole shares that kind of set of goals that the president has. You have House Republicans who are in mostly the repeal camp. They promised to repeal the law if they were elected. They're waiting for the repeal vote. The replace can come later, but the House is more focused on the repeal element. You have a set of senators, including my senator from Maine, Susan Collins, Lisa Murkowski, who went to her legislature last week and said, you know what, if they're going to repeal the Medicaid expansion, I'm going to vote against it because my state's expanded Medicaid and I want it. So senators are in a different place. And then as we speak, the governors are coming to Washington and they're all over the map as well. So I say that because the predictability of this debate assumes homogeny, like assumes there's Republican monolith and they know what they want to do and they're all working together. I know John Boehner retracted it a little bit, but he said yesterday, in my 25 years in Congress, there was never an agreement among Republicans on a health plan. And having worked with Democrats and knowing how hard it was to get Democrats to agree, it's very hard to get an agreement on a health plan. So I am pretty sure he was probably speaking truth to what his own personal experience is. So I will go back to the word hard. It is hard to make major change, legislative, even with the alignment of Congress and the White House. So I think we just don't know at this moment in time.
I mean, a lot of the core ideas that you hear talked about, high-risk pools or health savings accounts or even cross-state sales of insurance. I mean, they're not new ideas, right? They've been kicking around for a very long time. Are there any of them that, if done a certain way, you would support?
So there is a question about whether these ideas supplement the Affordable Care Act basis or replace it, right? That's, I think, a very fundamental question. Where do these ideas fit in the big scheme of things? And let's just take high-risk pools for 1 second. If they're talking about high-risk pools to say the insurance reforms in the Affordable Care Act that require an insurance company to accept people irrespective of their health status goes away, and the alternative is a high-risk pool, will it cover as many people? Probably not. We did a study in January before we left that found that 3.6 million people with pre-existing conditions who are uninsured gain coverage. I don't know that any high-risk pool program could find those 3.6 million people who gain coverage, move them out of a private insurance pool, move them into state-based risk pools, and solve the problem. Similarly, across state lines, Affordable Care Act included a policy that allowed states, if 2 states agreed, to sell across state lines with some consumer protections. Not one state asked us to do this. We never had any takers of that idea. So it's an idea that was out there, that continues to be out there, that hasn't been of great interest to states or insurance companies. So you can go down the list of these ideas. Health savings accounts, I think they're less about a health policy than about a tax policy. They're a special type of savings account with a special type of tax status that can be used for healthcare services, but there's not a lot of evidence that they change somebody's behavior when it comes to purchasing or that they're a substitute for insurance, and they certainly would not be a substitute for a premium tax credit as a means of getting a person between 100 and 400% of poverty covered. So it's hard to have a policy debate when we don't even know the parameters. We don't even know what's on the field, what's off the field. Are these complements to the existing system, or are they wholesale replacements?
All right, so I'm only going to ask you 2 more questions because I want to get the audience in on this. But based on what you just said, right, this mega period of uncertainty, you know, what is a poor insurance company or a poor provider supposed to do? You know, it's only months from now that plans need to decide if they're going to participate, you know, in the marketplaces. They have to price their products. You know, there's a point to which you just can't even price in uncertainty anymore. So, you know, what happens? Are they going to take a pass and sit out the next year? You think they're going to stick to it? You know, what do they do with all this uncertainty looming over them?
Sure. And if folks in the audience have views on this, I would love to hear it, because I've been in government and we worked on the other side of this equation for a long time. We did work very hard before we left to give the new administration the option of steady state, so that they would not have to do anything and worry about 2018. And I say that very deliberately. We finalized every single rule for 2018 before we left. We set minimum marketing budgets for 2018, so it would just happen. We had all of our outreach for the end of open enrollment on autopilot. They just needed to do nothing, and it would have continued. We had defended a bunch of our payment systems that are important to the insurance companies that are in court, and there was no worry that they would lose those funding streams in 2017. So the administration had a choice on day one. It could have said, you know what, we're going to debate Obamacare in Congress, repeal and replace in Congress, but while it's happening in Congress, we're going to keep a steady hand on the tiller and just keep going, because this should be happening in Congress and should not be happening administratively. They chose not to do that. So I am hoping that as they themselves look at the congressional debate, look at the calendar, recognize the fact that there's going to be potentially a gap between when they're done with what they're doing legislatively and when insurance companies have to make choices for this fall, that they go back to more of a steady state management approach. Because again, putting aside ideology, the idea of things falling apart because of, you know, lacking attention or not providing answers or not getting to a decision point is not the way I think anybody wants to run, as I say, a business, but run a government, because in this case, government and business are very similar. So I'm crossing my fingers that there's a growing recognition amongst the team of people who took over my job and my colleagues' jobs that debate all you want in Congress, but you have a obligation to keep things steady in the short run as we try to figure out what comes next.
Well, I could ask you a million questions, but I'm going to go in a totally different direction with this one. So the ACA is a lot more than just a health insurance coverage and expansion program. You know, there's just, you know, a laundry list of payment reforms, delivery system reforms, an enormous amount of public health related aspects in this law. You know, your thoughts on what happens with all of those things apart from coverage?
It's a great question. I'm going to start with the Innovation Center, because one of the humbling ideas that we had was in 2009, and even before that, was we always don't know what works and what doesn't work. And trying to create something that allowed adaptability so we could actually learn and modify and change Medicare policy without going to Congress every year or 2 years was something that we thought was an interesting idea. The fact that the Congressional Budget Office allowed us to create the Innovation Center, they could spend $10 million so long as that had a return on investment, so it didn't cost us in the budget bill when we passed the law. And we've had an opportunity to, in various ways, build that center into a very robust and interesting place where we are literally testing dozens of ideas, trying to figure out what works, what doesn't work. When programs don't work, we pull the plug. We've said no, and that's something that's hard in government, but we've done it. And vice versa, when we found that, for example, the diabetes prevention program, which is a well-boxed in intervention to bring public health types of interventions into the medical field, was certified as saving Medicare money and improving quality, we were able to put it into our rulemaking to be effective in 2018 that's an example of something that I think was smart policy because we didn't know the answers. We put in a system to figure out the answers. We figured out a glide path to get it into the healthcare system. And knock on wood, we have yet to see any retrenchment in that area of public policy. So in the area of how do we begin to align our payment mechanisms with our quality incentives with our public health, I think we made strides, and I'm cautiously optimistic that that set of activities will continue. Public health is going to be a harder one because we tried with the Prevention and Public Health Fund to supplement the annual budget process through appropriations to have a flexibility to redirect resources towards either programs that are unpopular in Congress or sudden emergencies like Zika so we could be more nimble. Didn't work out so well. Congress ended up earmarking that fund every single year, so we had no administrative flexibility with it. It's become kind of a place of offsets for different bills as we go forward. So I'm more nervous about our public health funding gains in the law, but we still do have a bunch of improvements in our connection between our medical system and our public health system that were made by the law that I think will stick.
All right, well, let's get the audience in. So feel free with this great crowd. Raise your hands. I'll try to work my way around the room. Troy.
I'll start. So, hi. Yeah.
And if you could just introduce yourself, please.
My name is Troy Oshner, and I'm the Deputy Superintendent for Health Insurance. So commercial
Yep.
health insurance world. And so one of the things that obviously we're grappling with, which you know, David asked you about, that we're trying to deal with on the state level, is unpredictability for 2018. We've got rates that are going to be coming in the coming months. And so and there's a lot of pieces of unknown. And of course, insurers, when there's a lot of unknown, either get scared or they want to price for that unknown. So what are, looking at the landscape, like the individual mandate and various other pieces that are in jeopardy, what kinds of things do you think on a state level we should be doing to try to maximize certainty and stability and reduce either flight or overpricing?
Yeah, there have been a number of experts and state officials who have contemplated whether having state fallback policies for the Affordable Care Act in place if the administration doesn't, for example, enforce individual responsibility or doesn't come up with some of the other supports that insurance companies need. So there's been that discussion. I think that instead, again, if the time frame is such that we will have clearer answers on whether there'll be changes for 2018 in the next month, 6 weeks in Congress, that process may exhaust itself before even a state can act. So I think the pressure is on. I think there's at least I don't know if it's good news, but it's certainly a reality is, I think the reality is the fragility of 18 is known to Congress, to the White House, to all the actors at stake. So I do think we're going to get the answers that I described sooner than later. Whether it's soon enough for 2018, whether it will avoid the fear and or higher prices, is hard to say at this point. I have, though, been working on this question of whether you could have a bill, like one of the bills that got introduced, this Cassidy Collins bill, that says, you know what, if a state wants to recreate the Affordable Care Act, so be it. It can be exactly like it is today in New York if New York wants to do it, but we're going to repeal the law and New York has to opt in to the Affordable Care Act. I am very worried about that kind of simplistic idea because, put aside the many interstate issues that are at play in health insurance, there is ERISA. Most ERISA-funded plans can't be touched by states, and we would find ourselves, I think, with a lot of problems were there to be these state-based approaches that are designed as substitutes rather than complements to the Affordable Care Act. So people are keeping an eye on some of the bills because it's putting undue pressure on states to say you can fix it all, because states can't fix it all, given some of the elements of our health insurance system.
Joe?
Joe Baker from the Medicare Rights Center. So, Jeanne, just an observation and then a kind of more political question for you, given your experience. And this, I don't think I'm talking about anything that anybody doesn't know in saying that, these proposals that we're seeing now are really about cost shifts away from the federal government to either the states or onto individuals with some, health savings account with some, instead of subsidies with a bit of money in there, but certainly not enough to, ongoingly sustain it for an individual if they really do have a health event, let alone a catastrophic health event. So getting that message of cost shifting over, the other thing is that supposedly the Republican plan leaked today, does use or does start to affect the deductibility or the tax-free nature of employer-provided plans if they reach a certain threshold, not unlike the Cadillac tax, which was incredibly unpopular, as you well know, from both sides of the labor and corporate, the C-suite and the labor suite, as it were. What do you think are the messages that you saw that, work to support the ACA that might have worked to undermine it, excuse me, and certainly what you see in the alternative plans that, not from the policy wonkish place perhaps, which we all want to go to sometimes, but the place that real people can understand very quickly that this is a threat. What are the things that you think might work, that might gain some traction in building a coalition, in building opposition, and or building support for certain pieces that could repair, if you will, as opposed to replace?
Got it. I'm going to take the question in three different parts just because it's a complicated question. I'm going to work backwards from coalition and what real people understand. You all probably know as well as I do, the complexity of healthcare is just enormous, and how people understand their healthcare, their own healthcare, their health insurance, the healthcare system is incredibly complicated. Going back to the fact that people don't know the Affordable Care Act and Obamacare are the same thing is just another example of it's just hard. So I don't know about the messaging part. I will say, going back to this, the mirror of trying to advance something versus trying to take something away, we learned the hard way that, the damaging words in 2013 were, if you like your plan, you can keep it, right? And the fact that that was so powerful to people is indicative of the fact that people don't like to have something taken away. So going back to this potential limitation on the deductibility of employer-based health insurance, if that's perceived as meaning I'm less likely to get job-based health insurance, that will be very potent. When I talk to my economist friends who have debates over whether there's good policy or bad policy, if you combine that with no employer mandate, with no individual mandate, with some sort of flat tax credit, you could see a significant movement away from employer-based insurance, which again would be something that would probably not be popular, again going back to the same reason why Cadillac tax was not popular, both among workers who value employer-based coverage and around employers who know that that set of benefits is valuable to their workers, to sustaining a long-term workforce for them. So it'll be interesting to see if they take that on. It's just unclear at this early stage, where employer-based coverage fits in. Going back to kind of why the Affordable Care Act is complicated, the president didn't want to touch it. Kind of want to say, move that over there. It's working. People like it. The genesis of that line was, I don't want to be going into the employer-based market and messing it up. I want to fill in the gaps of the individual market. And going back to surprises, we were surprised that the system works so well for the employer-based system. We have more people in employer-based coverage today than we ever expected. Congressional Budget Office projected that we probably have 4 to 6 million people losing employer-based coverage in the Affordable Care Act when fully implemented. They're wrong. We have more people than we have before. So it'll be interesting to see how that plays out. Do they really want to touch that third rail? And I think it's actually more of a third rail, right? Not more than Medicare, but it's become on par with Medicare as a third rail. But going back to this cost shifting point, which I think is very, very important. One result of the current debate that makes me sad is a year ago into the summer, I was working on a thesis about how the Affordable Care Act has helped us show you can tackle healthcare cost growth in the United States of America without arbitrary caps. Because we had. I mean, we really had proven that we could slow Medicare growth, improve its financial solvency, without having to resort to some sort of aggregate cap, premium support, voucher system, because smart reforms can, if designed right with the Innovation Center and our regulations and like all the right kind of tools and mechanisms, had made a difference in that cost curve. Fast forward to the fact that that feels like that argument can't be made anymore because all that Congress is talking about is some sort of cap on federal spending. I don't know that we can recreate that set of arguments, but it does have a basis in our experience in that past number of years. And I'm hoping if we get the time to have a real debate over health reform, those sorts of arguments and evidence can come back in.
Yeah, John.
John Gordon. Thanks again. I'm just to follow on the point you were just making there is, what do you think this means, not for the future of the volume to value transition writ large, because I think that, at least to me, feels like that ship has sailed a bit with macro. But more broadly, does it accelerate a move towards something that might look like capitation? All the other things that are out there haven't shown some progress, but not. It's just fee-for-service is still running strong, as much as we want to say otherwise.
Yeah.
So do you think any of this debate, does it move things faster? Does it slow it down? No change?
It'll be interesting to see. I'm fascinated by the fact that we have increased evidence that the parts of Medicare that are not full-blown capitation, the non-Medicare Advantage parts of Medicare, may be doing better at producing value and lowering cost growth than Medicare Advantage, right? There's just, we tried and failed to put into our regulations more even just reporting on value-based purchasing within Medicare Advantage. Couldn't do a lot of it. It's not that they're not doing it, we just couldn't actually kind of get inside that black box. Keep going and say, when we passed the Affordable Care Act, the projections were that enrollment in Medicare Advantage would drop because we were cutting out overpayments. It's gone like that instead. And there's still a lot of evidence that there is significant funding without a lot of pressure going on in Medicare Advantage. So it is an open question about whether we're going to do better at moving towards a value equation through Medicare Advantage, which may still be a blunt instrument in terms of trying to incentivize preventive care coordination and value, versus some of our intermediate models like accountable care organizations or bundle payments for sets of episodes in terms of finding the right constellation of actors and incentives to really move towards it. So I think the answer is still unknown, but I'm encouraged by the fact that we have natural experiments, good evaluations going on, people are trying, testing, the private sector is working well with the public sector right now to kind of share those data. And I'm hoping that we'll get more information, with the idea being maybe there's not one right answer, but maybe there's different answers for New York City and rural New York and different parts of the country, where we can figure out how to adapt some of the best practices that are working in particular markets to places.
Yeah, Art, and then we'll go here.
Hi, Martha Webb, a consultant here. First of all, thank you for your public service.
Thank you.
That's really great. I'm sure you haven't even started your decompression.
So I was just saying, I sound a little hoarse because I didn't take a day off after the administration ended, and my body told me that was a bad idea, and I got really sick. So, yeah.
Yeah, well, sometimes stress is good. And there's many in the audience who are either current public officials or former public officials, so I totally appreciate what you're going through. I'm not going to talk about Affordable Care Act. I know your great experience. What's really exciting you these days? What are some of your free thinking, so to speak, in terms of whether it's health reform or just plain good thinking? What's the kind of things that are going to make you excited than going into the White House every day?
That's really funny. So, for better or worse, I have learned that the Affordable Care Act was not a job with a title in the White House. It was something that has carried with me and my team to the point where I literally was on a call yesterday with people all over the country who are my team in the White House but are still working every single day from different vantage points to try to ensure that the progress that we make continues. So it's hard to say that there is that period of time is over just because the paycheck stopped and a different team is in charge, primarily because the importance of communicating what worked, what didn't work, trying to make sure that different actors in Congress and in states understand what's going on, trying to bring evidence to bear on this debate is just too important. So I need to say that as a contextual point. I would say that a year ago, into the spring, into the summer, I was thinking that way. I know, and I was inspired a little bit by the president to think this way because he wanted us to look beyond the horizon. And horizon for us is usually like day to day. I used to wake up every morning at 5:30 to see what was my 7 o'clock call and what my 8 o'clock call was. But horizon being 3 to 5 years from now, where do we think the health system was going, and how do we titrate, modulate, radically change our planning to get there, right? And put aside the fact that we spend all this time talking about the individual marketplace where 6% of Americans are insured. That's not a lot of people, right? But that's where the debate is. That's where everything's going. We were going back to this argument about value. How do we begin to have a learning healthcare system that's adaptable, that can incorporate technology, that uses evidence to begin to improve outcomes and performances, that recognizes that sometimes just paying a lot for something that doesn't work is not a good idea, and how do we refocus that? I mean, we still, even though we've slowed our health spending as a percent of our economy, still have the most expensive healthcare system in the world, and we still could do a lot more with the same resources were we able to kind of figure out smarter ways to do it. So going back to like Medicare as a model, Medicare as a leader, Medicare then leveraging relationships to begin to do more systemic work that makes more sense to providers, then beginning to get state officials involved, other programs involved. The amount of good that we could do simplifying the system and having it be just more aligned to a set of outcomes through our public programs is just enormous. You can imagine all sorts of ways to, simplistically, how do we get Medicare Advantage, Medicaid managed care plans, and individual market plans, which may be run by the same single insurance company, right? It could be one company running plans with all these three programs. Some of them are working really well, and the marketplace is failing, and Medicaid managed care is doing okay. One insurance company, one government, 3 programs. How do we begin to align them to make more sense? That was a longer term project that I think we started thinking about a year ago. I started thinking about a year ago. And maybe if I wasn't doing what we just described earlier, is reading the clips every morning to see if there's something new on the horizon, I hope to focus on, if we indeed get back to a saner place where we get back to kind of, I'm going to call it new normal. And here's why I am optimistic. Somebody mentioned MACRA earlier. MACRA is the Medicare reform bill that got passed in 2015. Let's just talk about that for 1 second. Compare and contrast Affordable Care Act. The Medicare physician payment system, for all of you who don't know about it, was seriously flawed. We had 17, I think, different cliffs where payments were going to get cut, had to act on it all these years, had ideas of how to fix it, took a long time. But finally, bipartisan, smart policy, got enacted, overwhelmingly bipartisan. We had a Rose Garden ceremony with, you name it, John Boehner was there, Orrin Hatch was there, the president was there. This is not like ancient history. This is not like before Obamacare. This was a year and a half ago. And then we did a proposed reg. We had some good things in it, some not so good things in it. We listened, we learned. We had a tech team involved in developing the regs, so we're not worried about a website crash on MACRA. We have models about how we can govern. And like, you know what? That's good enough that we haven't heard that the new administration is gonna significantly deviate from it. There may be congressional fixes to that particular bill that are just gonna happen without drama. They're just gonna happen every year or two like we used to do in different programs. And I give that example because it is not impossible for our political system to get out of the ideological warfare and get back to normal, even in healthcare, even when billions of dollars are at stake, even when Medicare is at stake. So you talk about predictability. Let me not predict what's going to happen in this debate. Let me do my hope or my aspiration. My aspiration is that the pendulum, which had been like Obamacare, Democratic, big government system, to now Trumpcare, big fight over repealing and replace, settles, and it kind of lands somewhere in the middle where we get over it and we begin to do common sense fixes through public policy. But again, going back to your good question, which is like, but where do we want to be 5 years from now? Begin to try to develop the next round of health reform, because I do think we're not having a robust debate right now. There are a lot of stale ideas, but we do need to figure out what is that next stretch goal that we need to figure out in public policy to make this system, which is complicated, which is still too expensive for many people, better.
I know we had a question down here.
Elizabeth Gillespie, I'm with HRH Care. We're a federally qualified health center.
Great.
We serve about 170,000 people throughout Long Island and the Hudson Valley through sites located throughout. And so when you were talking about public health, I mean,
Yeah.
we are fearful.
Yeah.
Annually, I have been really kind of surprised that appropriations to community health centers have been kind of nonpartisan. It's like the Republicans seem to understand that we serve populations that, are good to be served, and the Democrats are very supportive. So annually the appropriations are renewed, even though we get to the cliff and then we don't fall off, they're renewed. Yeah. So I know you're not prescient or you don't want to be a predictor, but are you getting any sense of a huge chunk of our annual budget is this federal funding that we've been fortunate enough to get through Section 330. So, we're scared.
Sure. I'm a bad news first person, so I'll start with my bad news and do good news. The rumor mill around the new president's budget. Remember, you don't really do a full-blown budget in your first year. You do kind of a framework, which I believe might be part of the president's address to Congress on Tuesday. That's what we did in 2009. I think that probably will be somewhere related to it. But the rumor mill suggests it's going to be a harsh budget, a very kind of low domestic discretionary budget. So there should be worry about that. But for community health centers, we talked about the prevention fund a little bit. We didn't talk about the community health center fund, which was in the Affordable Care Act, and then got extended in this macro bill we just talked about. That funding will continue, but only through October, and is tied up with legislation for Children's Health Insurance Program, for a bunch of other programs that does expire at the end of October. Medicaid dish cuts, if all of you follow that, that's also October. So we have two different separate, distinct from Obamacare, repeal and replace things to focus on that matter for healthcare. You're absolutely right that the discretionary budget from HHS really matters. Now, going back to being optimistic, we have over the years not seen a big appetite to cut the 330 program at HHS. And remember, the Republicans have been in charge of Congress now for years. So I don't know that anything has changed, so that should be a greater risk, especially with what's going on right now and the uncertainty. But one doesn't know. I'm more keeping an eye on this must-pass legislation that would extend the Community Health Center Fund, extend CHIP, and extend a few other programs. That is slated, needs to happen by October, or else that funding goes away. So.
There's a number of people here from the reproductive health world. Where do you see that debate going?
I spent many hours of my career working on women's health issues, and I'm quite proud of our record on that. We even tried in our last year to ensure Title X funding is provided equitably and not discriminating against providers of services that are not funded by federal government. All that said, who knows what is about to happen. Paul Ryan has reiterated that he wants to defund Planned Parenthood as part of his Obamacare repeal and replace bill. They did that in the 2015 bill that President Obama vetoed. I haven't looked at the leaked draft to see if it's in there, but that's something to watch out for. The note of optimism, though, is that there is a fair amount of other regulatory activity that could be done. They did do a Congressional Review Act on the rule I just discussed about Title X, yet they haven't touched at this moment in time the contraception rules that we spent many, many years working on, that as part of preventive services for private insurance, women's prevention is covered and contraceptive services are covered as part of that. To date, we haven't seen or heard anything about what they might do with those rules, so we shall see. And, we're worried. But it's hard to figure out where this will come from, how it will happen, and how it will manifest itself. But when I was doing my planning, because I told you all I ever do is plan for bad things. So I was planning for my first day unemployed on January 20th about all the bad things that they could have done on Inauguration Day. I had put this on my list, that they would go more aggressively after women's health on day one. And they did the global gag rule, so they did the one that was predicted. They could have done more, and they haven't. But that's no cause for optimism. It just means maybe they haven't gotten there yet.
Hey, other questions? Marjorie.
So I have a question that really comes out of the intersect between health policy and immigration policy. Want to get your sense of your administration's effort to strike a balance between those two during your tenure, and what we on a local level and on a state level should be thinking about as the immigration enforcement conversation goes on and starts to compel, at least we're hearing anecdotally, compel immigrants, and particularly those who may be regularizing status or undocumented, to go underground from the healthcare system, even because of their concerns about how information is going to be used and what they may jeopardize themselves with by even taking health care. And what does that do to the public health sector, which is going to be the only sector, which may be the only open sector for them?
Sure. I work very closely with our domestic policy council advisor, Cecilia Munoz, who you might know from her work on immigration policy over the years. It was always the area of immigration and healthcare, the overlap was always so challenging. It was actually arguably one of our most challenging areas, because it's just hard to figure out how you both want to mainstream folks but not put them at risk. And I will fast forward to the fact that New York is one of the 2 states that have implemented basic health plan, which is good. That's all I'll say. And we did have actually a back and forth a lot with California this year on this very issue, because put aside basic health plan, California had passed a state law that would allow undocumented people to purchase unsubsidized insurance through the marketplace in California, through Cover California. And there was a debate about they could purchase coverage outside the marketplace. They wanted to go inside, primarily because of mixed status families and you're losing people who were eligible because of the fear of coming in a unified family. So California made a compelling case. They had an application in. They withdrew it. And they withdrew it for exactly the reason that you articulated, which is a community fear that those data that will be in the Cover California website could be used for other purposes. Now, we went over the laws on this. Couldn't be. We think it would have been legally challenged. I think there's a lot of smart lawyers who are actually on this issue as we speak because of the fear. And let me flip. This is not a fear without consequence. This is a fear that is dissuading people from seeking health care that they need. And that is a tremendously big public health problem. So there are smart people, again, looking at this and trying to make sure that there's enough both legal basis for protecting those people's data, there's enough educational material to safely educate people about what their options are so they don't find themselves getting bad advice and putting themselves at different types of risk because of that bad advice. But I will flip it around and say this is why the social safety net in this particular year is especially important. We talk about community health centers, you name it, the Medicaid dish cuts. In an era of uncertainty, we need our safety net more than we otherwise would. So the idea of cutting it back is even more problematic as we are trying to make sure that we have institutions there that are more trusted potentially than some of the more mainstream healthcare systems for people in disadvantaged communities. So it is an argument for pushing harder for state officials, for the federal officials, to make sure, especially right now, our safety net is protected.
We have time for maybe one or two more. I think I see a hand.
Hi, Alice Berger, Planned Parenthood of New York City. And I just actually was sort of smiling because my wonderful colleague, Joan Allen, our CEO of Planned Parenthood of New York City, the two gray-haired women sitting here.
I have gray hair from working on your issues, trust me.
We should talk afterwards, yeah. First of all, sort of thank you for your sort of historic support in terms of reproductive health and sort of women's preventive health services. And I'm just sort of amazed about, in general, your level of moderation and sort of optimism. Now, maybe that does come with the hat that we wear, but to just sort of make a comment and then ask a question that sort of piggybacks on the FQHC, sort of your comment, is that we have recently gotten some intel about that there actually will be an increase in funding for the community health centers, but that there is a thought that that is going to be pulled out of Title X. So clearly, if you're talking about sort of changing tax structure and you're talking about sort of cost reduction, it's got to come from somewhere and go to somewhere. And so, again, this really does go beyond sort of women's preventive health services, but it's just, there's so many moving targets of where the hit can be. And again, part of the intel is, again, and it changes every day, as we know, that there might be some language about sort of defunding, Medicaid defunding for Planned Parenthood for a year. But again, this sort of changes all the time. So just sort of your thoughts about that and how that fits into the really attempt to sort of radically change the tax structure, and we know who is targeted to benefit even more than they currently do.
Sure. I'm going to do a 4-part answer to that question. It's the last question, right?
Sorry.
Actually,
I'm going to ask the last question.
Okay. So calibrate my answer then. 4 parts. Number 1, let's talk about taxes for 1 second. We have heard that there is some thought that in these bills there might be these health savings accounts and there may be more additional restrictions on the use of tax funding for certain types of services that they find morally objectionable, like abortion services. I think those are such non-starters. I think a lot of people are beginning to push back on that. Just so that is on the horizon. People are familiar with that. People are watching. Going back to this trade-off between the community health center funding and Title X, that was in the 2015 bill. They plussed up community health center funding, not connected. There were different sections of the bill. They plussed it up over here, and they defunded Planned Parenthood over there. They don't say Planned Parenthood. It's a complicated little formula that they use in the language to get at Planned Parenthood. But I would say, in credit to the community health centers and the people who do research on this, there's a lot of evidence that because of that bill came out to say will not work as a substitute. Important that these clinics have funding, and more funding is good, full stop. But the idea that that's going to be a substitute for these different types of clinics in different locations with different skill sets, different services offered, doesn't work. So I think the readiness about this, and this is again why sometimes leaks are informative, because it means you're not getting surprised with something and people are reacting to it with no time. There is time for research to be done to say, what does this mean? What does this matter? Does this work? Does this not work? And what are the arguments? So I think that debate over the push and pull between these two funding sources, I think, is already being broached by a lot of experts in the health services research field. I'm in intrigued, though, by the debate, because there's two different debates. There's a debate over women's health, which is harder for, I think, members of Congress to have. Nobody really likes to talk about it. And then there is a debate over Planned Parenthood, and they are different. I mean, they are separate things, and I think we've seen some backlash against the singling out a particular organization like Planned Parenthood, which is pretty popular in many parts of the country, to the point where Lisa Murkowski and Susan Collins have both said out loud, we're not going to vote for a bill that does that. And by the way, they need 52 votes in the Senate, and they're 2 down. They only have 1 to lose. 1 more senator, and they can't pass a defunding Planned Parenthood bill in Congress. Just note that. But we also saw at the Republican retreat that happened in Philadelphia, there was this leaked tape about, there's lots of leaks going on, a leaked tape about the conversation, and one Republican congressman said, Planned Parenthood's going to become to the left what Lois Lerner and the IRS was to the right as an organizing tool. Why are we taking on something that's for ideological reasons that's going to become problematic for us? So there's a long debate to be had here. I mean, it may be, again, like intense in the next 6 weeks, but I don't want to discount the fact that we have these examples that are concrete, real examples of, of evidence that this monolithic march to repeal, to defund Planned Parenthood is not inevitable. So let me do my last point, my fourth part, or your question, which is why am I optimistic? So optimistic is not the right word. I still have not taken my break. I still have not taken a vacation. I have not thought my big thoughts. So that's not a sign of a person who is super optimistic about things. But I am a believer that this country does well when we work together, we're smart, we use facts, we use evidence, we use real-world experience, and we continue to put that in front of people, in front of policymakers, at town hall meetings, in hospitals, in the halls of Congress. I believe in that model. I've seen it work, and I've seen it work when nobody else sees it. That's, I think, probably the unique position I've had. I've seen it when nobody else is in the room, there's no audience, there's no historians who are going to write down whether or not something works. I've seen people act when there's a decent goal, and again, I hope that the president shares the goal of covering people and trying to make the health system better. If he shares that goal, and we can begin to get back to a world where research matters, facts matter, evidence matter, people's voices matter, I think a lot of what has been accomplished will maintain. The parts that may not work so well may be changed, but that happens in Medicare, it happens in Medicaid, it happens in all parts of our healthcare system in our society. So change happens, but major change is hard, and change that runs counter to the grain of things that are working and things that are helping are particularly difficult. So that experience gives me cautious optimism. Cautious, not
I think that's pretty optimistic, Jeanne. So I think we're going to I'm taking it. Okay. We're going to wrap there. So first, I just want to thank you so much for being here today. You were just as great as I knew you were going to be. I have to take this opportunity to plug a few more upcoming events. If you're interested in our work on veterans' health, be here with us on March 14th. Where we'll be doing an event with the Patent Veterans Project, an organization that we just recently recognized as one of our 5 top emerging innovators in all of New York State. It's going to be really cool. This room, we're going to serve you lunch, so don't miss it. And on March 28th, we're going to continue our focus on health reform. We're going to have another national health policy star. We'll be hosting Sean Cavanaugh, who until very recently was the national head of the Medicare program, and he's going to be here to talk about what might be next for Medicare. Our invitations are going out next week, so keep your eyes open for that. There's always a lot going on at the New York State Health Foundation. So I encourage you to visit our website, join our mailing list if you're not already on it, although so many of you are familiar faces, I bet you are. If you really want to keep up with what's going on with us on the regular, then I invite you all to join and follow the foundation on Twitter and follow me on Twitter. You can see our Twitter handles on the handouts on your seats. So thanks again to Jeanne for being here and for all of your work over so many years. You deserve that vacation. I hope you get it. I wish all of you a very great weekend. Thank you.